All right. Good afternoon, everyone. Thank you for joining us for Home Care Assistance's Dementia360 speaker series featuring thought leaders reporting from the front lines of dementia. Some of you may have been on the last presentation with Dr. Golizade. Really excited for this next presentation on meeting the physical needs of people with dementia. But today, Alzheimer's disease and other types of dementia touch hundreds of millions of lives, from the people living with the condition and their loved ones to professional caregivers and healthcare teams. Our goal over the next few weeks is to provide you with a comprehensive perspective on the most up-to-date research, caregiver support, prevention tips, and more, so that no matter how you're impacted by dementia, you will walk away with tools that will be helpful to you or someone you are caring for. Introducing our second speaker of today, Dr. Beth Popolizio. She is a physical therapist with almost 10 years of experience in neurological rehabilitation, treating patients with a broad spectrum of acute and progressive neurological diagnoses. She received her doctorate in physical therapy from UCSF, SFSU, followed by a residency in proprioceptive neuromuscular facilitation at Kaiser Permanente. Her career began at the renowned acute rehabilitation unit at Alta Bates Summit Medical Center in Oakland, California, where she worked closely with interdisciplinary teams to provide patients and families the tools to transition home. Her clinical experience spans the spectrum of acuity from intensive care to outpatient therapy and home health, and she holds an adjunct professorship in neurological rehabilitation department at Samuel Merritt University. During her tenure in clinical practice, Dr. Popolizio recognized the need for skilled home caregivers and leveraged her experience to develop and implement a mobility skills training program at TheraCare Home Caregiving in Redwood City, California. And she is now, drum roll, training and development specialist at Home Care Assistance, where she develops and delivers curriculum for field operations staff and participates on the Memory Elite team to build the dementia-specific service line. And with that, no further ado, I'm gonna take it over to you, Beth.
Hi, thank you. Thank you all for being here, and I'm excited to be addressing this topic with everybody. So by the end of this talk, my hope is for you all to have gained an understanding of the features of mobility, specific considerations regarding mobility for people with dementia, and to learn some strategies for providing support in the realm of mobility. Before we get into specific mobility considerations for people with dementia, let's first talk about how we think about providing care. What you see here is an intention to put into words the shift of the care paradigm for something that is done for or to people, sometimes at the expense of their own autonomy, to a partnership where both people, carer and caree, are engaged and participating. The job of a carer is to provide people with dementia a safe environment where they can be as independent as possible, to consider all aspects of their personhood when caring for them, and to support them in living a full life that includes participating in the things that bring them joy. So what are we really talking about when we refer to mobility? It seems intuitive, right? But when you start to think about it, mobility is really a multifaceted entity. For our purposes here today, it can be broken down into two categories of physical and functional activity. Physical activity refers to movement that does not necessarily relate directly to parts of daily living. This can be therapeutic, cardiovascular, or resistive types of exercise. Functional mobility, on the other hand, is movement specifically required for the completion of activities of daily living, like bathing, grooming, and toileting. There is an intersection between these two, and physical activity can be used to improve functional performance, but the purpose of support and the intention around each might look a little bit different. So why are my mobility considerations so important? Well, for the geriatric population, fall reduction is a significant concern. And for people with dementia, it's an even greater one. Impaired cognition is associated with poor balance and gait disturbances, as well as an increased likelihood of individuals living sedentary lives. So a positive feedback loop of decreased activity, propagating declining reaction time, increased muscle weakness, and further impaired coordination begins to regenerate itself. As a result, people with impaired cognition are twice as likely to experience a fall versus their cognitively intact counterparts. And the incidence of fall-related hip fractures is threefold that of people with normal for age cognition. There's also higher incidence of post-fall complications and institutionalization for people with dementia, which can cause significant distress for individuals and their families. So ensuring regular and safe participation in mobility can help to maintain system strength and decrease the risk of an individual experiencing a fall. Beyond just injury prevention, physical and functional activity are primary non-pharmacological interventions used for improving perceived quality of life. One 2018 study found that ADL, activity of daily living training alone for people with dementia in care facilities, resulted statistically significant improvements in 3 separate areas of quality of life. That's care relationships, positive self-image, and feeling at home. Related to quality of life is the preservation of dignity. The Mann model of dignity identifies 3 potential violation scenarios, which are a person not being seen, respected, or acknowledged, a person being seen, but only as a member of a group. And we see that example in healthcare in diagnosis forward language as opposed to person-centered language. And 3, a person's space being invaded by others. So providing people with the right level of support that recognizes their strengths and allows them to maximize their ability ends up being a person-centered care practice that preserves all 3 aspects of an individual's dignity. Participation in mobility and the resultant maintenance of skills and independence also sets individuals up for successful aging, which is in part characterized by the slowing down of functional losses and use of adaptive strategies to prolong and promote independence. And finally, and by any measure, equally as important as all of the others, the last consideration is carer safety. Awareness of environment, setup, and approach makes activities accessible for people receiving care and ensures the physical and emotional well-being of the person that's providing that care. That brings us to how mobility can actually be supported. So common imagery for providing mobility support is pushing a wheelchair or bringing a utensil to someone's mouth or physically assisting them with a transfer. And all of those are definitely forms of support, but they are by no means the whole picture. Facilitating movement includes all of the factors associated with producing a physical response. It starts with the right kind of approach and includes environmental setup, effective cueing methods, and selecting appropriate adaptive tools to pave the way for the movement to occur. Mobility support means being advocates for physical and functional activity by identifying and incorporating the right motivating factors. A recent study found that people with dementia in care homes spend about 72.1% of the day sedentary, which is more than 23% less daily activity versus community dwelling counterparts. It's the role of the carer to promote engagement and participation in mobility by using motivational techniques specific to that person and at the heart of person-centered care. This is a different mentality and requires us to create different intentions than the model of a carer just as a completer of tasks. And it's through facilitation of movement and promoting mobility that we actually support an individual's independence. If we consider again the factors of dignity and quality of life associated with autonomy and personal space, it's easy to conclude that supporting independence plays perhaps one of the most significant roles in actually living out and embodying person-centered care. And from all of this, we can put together a broad care philosophy. So in a nutshell, it is that all people have the potential for some level of independent function. It's the responsibility of carers to recognize individual strengths and use that to facilitate mobility while allowing them the time and space to perform at the height of their own abilities. And through this, we're actually validating personhood and autonomy and supporting that person with dementia in creating their own joy and purpose in life. Besides being good for a person's self-confidence and emotional state, providing opportunities to utilize strengths and participate in mobility is actually physiologically good for the brain. It's been shown that physical brain changes can happen when certain conditions of activity are met, and these principles are called neuroplasticity. These are a few of the conditions that can be applied to how we care for people with dementia. The more we practice things, the better able we are to preserve or even improve our abilities. That's true for learning throughout our lives and remains true for people with dementia. It's also the foundation of our first two principles. Take eating, for example. Let's say someone starts having difficulty bringing a fork all the way to their mouths, and a carer automatically jumps in to pick up the fork and complete the activity from start to finish for them. When that happens, we're actually pushing the mute button on the parts of the brain that coordinate that activity. So not only is it impossible for that person to improve, but we're actually contributing or could be contributing to the deterioration of their existing abilities. And that's why it's critical to take time to set people up for performing tasks, which is with as much of their own independence as possible. Next on the list is saliency. And saliency refers to the meaning that we attach to something and how that impacts the way our brain encodes it. Classical conditioning is a great example of this. So if an animal hears two sounds, but only gets a treat after one of them, the treat sound is going to rank higher on the importance scale, and the brain will adapt to produce a response. So how does this apply to care? It tells us that meaningful matters. If a person doesn't see any reason or importance behind something, they're not likely to engage in or pay much attention to it. Meaning can be found through getting to know an individual's life story and using that to incorporate familiar tasks in their daily routine, or just using it to motivate them in participation in other things. So like learning that someone used to enjoy making dinner for their family every night, including sitting at the table and having conversations with everybody. That could be an excellent avenue for engaging someone in activity by bringing them in to help with meal preparation. Repetition and success somewhat go hand in hand. We know that repetition drives learning. That's why we practice new skills. For people with dementia, we add the element of consistency to that. People with dementia don't learn by trial and error the way we do for most of our lives. Repetition of activities performed need to be done under the same conditions, with the same cues and tools where they're able to be successful in completing that activity. This setup is actually better for skill acquisition and retention for people with dementia. For carers, that means being observant and managing environmental stimulus, being consistent with the verbal and visual cues we use, and providing physical assistance only when needed and at the appropriate level. So with this, let's keep these principles in mind and watch a brief video that will demonstrate what it looks like in action.
spoon. Lift the spoon. Lift. Lift. Good job. Well done. Okay, now lift. Lift the spoon. Lift the spoon. Good. I need the balls put back in the tray. Orange balls are in the orange bowls. Can you help me, please? Excellent work. Well done, Chen. That's fantastic. You got them all correct.
Would you help me put the pegs on the container? I'm going to peg them like this. Would you help me do that? You hang on to the peg for me. Hang on to the peg. Will you put him on the container for me? Very good. Yep, squeeze the top. Well, how easy was that? That was good, wasn't it?
You go well, Trey.
You're doing well. Is that nice?
So being successful in working with people with dementia starts with the approach. How you introduce yourself and the environment you create can make all the difference in how an interaction will go. People with dementia retain what's often referred to as emotional memory. This means they're likely to remember how a person or situation makes them feel, even if they don't remember that person's name or maybe where they are. Creating a positive experience will help activities go more smoothly in the moment and potentially set you up for a good relationship in the future. Starting with warm and welcoming facial expressions and body language will set an initial tone and help to diffuse situations on the verge of escalating. People with dementia experience changes in their visual field and acuity that can ultimately make it feel like they're looking at the world through scuba goggles with Coke bottle lenses. For carers, that means you want to present yourself and the tools you're using, whether it be a comb or a spoon or a toothbrush, within their field of vision, which, and especially in later stages, is often better centrally than peripherally. Eye contact and physical contact are means of nonverbal communication that ensure the person receiving care is an actual participant rather than just a subject of it. Processing speed also changes as dementia progresses. That means people take longer to respond to questions or movement requests, and modulating the cadence of your speech using simple and consistent verbal commands and allowing time between communication, again, allows someone to be an active participant in their care. And it's more likely to be beneficial in preserving their independent function. This all sounds fairly intuitive and simple, but the reality is some days this will be hard to do. We all have busy lives, and as we just heard from Dr. Golizadeh, lots of emotions can arise when working or living with people with dementia. When you start to feel overwhelmed or those emotions start to creep up, that's when it's important for carers to recognize that we need to step away. It's time to remind ourselves of our intention behind care and reframe difficult situations using the language that Dr. Golizadeh just taught us. It's also important that we recognize our own resources are running low and how to best take care of ourselves so we can continue to provide support. So let's watch another video that highlights an approach technique, a couple different approach techniques, and we'll have some points of discussion to dissect what's happening here.
You haven't changed yet? Oh boy, looks like we've got work to do. Let me get some things to pretty you up. Okay, now where to begin? No, stop! No, stop! That hurts! I'm just brushing your hair, no big deal. That hurts! Ow! No!
So there's lots we could say about the approach here. The carer came in outside of the client's line of vision. She didn't connect with her at all before performing activities on her, not with her, which was alarming and distressing to this woman. The carer's body language, tone, and words did not communicate caring or that she really even was seeing the other person in the room with her, thereby violating a couple aspects of her dignity. These are definitely important things to note, and what we see here is a pretty overt lack of caring. What's actually more typical in a care setting or in care situations is that the carer is distracted or feeling overwhelmed or experiencing their own internal environment, and they don't notice their own ineffective timing, language, or tone. So again, that's why it's important to check in with ourselves before, during, and after interactions to see how we're presenting, how we're coming across, and make real-time adjustments to it. Now let's watch another approach and see how that goes.
Hello, Mrs. Jones. I'm Angela. Looks like you're ready to get your day started. Mrs. Jones, would you like to fix your hair and put on some makeup? Okay, great. Let's just walk over here so we can find your hairbrush.
The primary differences here are connection, cadence, and tone. Here, the carer called Mrs. Jones by her name and made contact to ensure she was ready to participate in what was about to happen. You may have also noticed that more was accomplished in less time. So while we talk about decreasing our speed and modulating cadence, it gives the impression that these methods are time-consuming, but that's not always the case. And in trying to do things quickly, like we saw in the first attempt, we can actually create an escalated situation that will ultimately take more time, along with psychological and physical resources to manage, than if we just connected on the front end. So let's continue and see what else can be accomplished with this kind of method.
Here, your hairbrush. Some lipstick. What would you like to do first? Do you want to brush your hair?
Yeah.
I like how you're fixing your hair. It looks real nice. What's next? That color looks good. What would you like to do next? Sure, you can add a little blush. That'll add nice color.
In that final segment, we see the carer communicating with Mrs. Jones and engaging her in the activity instead of doing it all for her. We also see her modulate her level of assistance, moving from more to less assistance based on the activity and providing Mrs. Jones with increasing independence as they go along. It fosters a successful interaction immediately, but as we now know, it also supports her in maintaining autonomous function and contributes to successful aging in the long run. So let's talk about what modulating assist levels looks like. It means we provide assistance to meet someone's needs while letting them use their own strengths. These levels are adapted from the Functional Independence Measure, which is a 7-tiered tool used by hospitals and clinicians to objectively measure and assess levels of assistance patients in their care require. This kind of tool is not often used in home caregiving settings, but can be useful to communicate between carers to improve continuity of care, can be helpful in training, and can be useful when families are trading assistance duties or caring duties. It can also be useful for observing changes in someone's ability and trigger our own adaptations or indicate that a response is needed. For example, urinary tract infections are often accompanied by a precipitous drop in functional independence. This adaptation of the functional independence measure is meant to guide carers in providing assistance, and it covers the spectrum of care from relative independence with invitations at level 1, where the person is best assisted using verbal or visual cueing rather than physical support, to guiding at level 2, where a carer starts to provide some physical assistance to initiate, complete, or just intermittently throughout a task, like we saw in the video with Mrs. Jones. And finally, to assisting at level 3, where more significant physical support is required, but the person being cared for is still engaged as an active participant throughout activities. Before we think about providing any level of physical assistance, though, we want to set up an environment that's conducive to performing the activity. People with dementia may have heightened sensitivity to environmental factors like temperature, noise, and visual stimulus. When we can manage those things, we're setting the stage for a positive experience. Drying someone off with a scratchy towel may make the difference between whether or not an adverse reaction to bathing becomes a pattern. Whereas turning on music they enjoy, having warm towels at the ready can make it easier to encourage their participation in the moment and in the long run. Being aware of these things also helps us determine when and how to support people. So let's say you're in a doctor's waiting room with someone that you're caring for. There are a variety of unfamiliar stimulus. It might be useful to use level 2 guiding strategies, like offering a handhold for walking, even if this is someone who usually responds to level 1 invitation strategies. This can work to give them a greater sense of security and limit the amount of cognitive processing they have to do in that moment. Ultimately, we get down to actually performing physical and functional activities, but it's not all about providing physical assistance still. Getting people set up with the appropriate body positioning, providing the right visual and verbal and tactile cues, and finding practical applications for the principles of care that will preserve function, impact quality of life, and honor the dignity of the person being cared for. The goal of mobility support is producing a response. We're trying to maximize individual strengths so they can participate at their own optimal level, wherever they are and however that changes. Carers should always be observing, and before going straight to providing physical assistance, going through this mobility action planning checklist to see what might be modified to improve the experience for both people. It's often just as simple as lowering a seating surface so a person's feet are on the ground, or changing your long, complete sentence verbal cue to just a single word. Once you've found that sweet spot, it's important to be consistent. Familiarity, routine, and consistency, as we've learned, are important factors for helping people with dementia recognize activities and perform them successfully. Today, I want to highlight visual and verbal cues in particular and provide some strategies for successful use of these to facilitate mobility. We all use visual input in our everyday lives. Think about how you know which public restroom to go to or when to stop and go while you're driving. Even if you're in a foreign environment, visual cues can help you orient yourself. So visual and, as we'll see in a moment, verbal cues are meant to help people with dementia reorient to activities and be able to participate at their fullest potential. Visual cues can be used to initiate, sequence, or improve accuracy of a movement. So for example, providing the right tool for an activity like a hairbrush or a fork, or even a walking aid like a walker, can trigger the response. For multi-step activities like dressing or rolling in bed, movements can be sequenced by providing the right cues at the right time, like a t-shirt before pants, or tapping on a bed rail to indicate that it's time to roll over. Accuracy can be improved by providing visual targets, such as brightly colored tape on the handles of a walker, so someone knows where to reach, or a contrasting seat cushion so they know where to sit down when you give them the cue. As we've talked about before, people with dementia experience changes in their visual fields, and high contrast items can help them see where they're going and what they're working with. When it comes to verbal cues, the process of orienting and reorienting, punctuated with periods of observation, helps maintain a person's attention to task and provides them time for processing and then producing an action. The Oreo technique of verbal cueing, published by Dr. Lisa McCarthy in 2018, outlines a specific sequence of cueing to meet the needs of people with dementia. It involves initially orienting a person to the task at hand and providing rationale, like, let's brush our teeth so they stay healthy and we can use them. Followed up by reorienting when necessary and providing positive encouragement if the person becomes distracted. Then throughout the activity, the carer is observing and ready to assist, but only when needed. A critical element of this technique is timing. This is not meant to be just a checklist of cues that are given in rapid succession. It's based on observation and specifically constructed to account for the changes in processing speed experienced by people with dementia. So another important component of this technique is that both people, the carer and the caree, are attending to the task. When someone is actively engaging mobility, it's not the time for the carer to try to multitask. A person with dementia may become distracted by whatever it is that you're doing, or forget where they are in the sequence of their own task. And you can see how if a carer looks up from whatever they stepped away to do, like fold the rest of the laundry or make the bed, and the person has stopped brushing their teeth, that can set the stage for frustration. And we can get into a scenario like we saw in the first clip with Mrs. Jones, where tone and behavior might not reflect the care that we're actually trying to provide. There are a few specific considerations we want to keep in mind with our verbal cueing. The first we've touched on throughout this discussion, and that's timing. We want slightly more time between words and longer pauses between sentences or movement requests. This overlaps with rhythm. Matching the rhythm of cues with the pace of the activity helps generate a pattern and maintain inertia. Your cueing rhythm for gardening, for example, may be slightly different than when you're trying to go for a brisk walk. And for some diagnoses like Lewy body dementia, specific and repeated auditory cues, such as a metronome, can actually help a person maintain the rhythm of their activity. Consistently using the same cues for common activities will help people become and stay oriented. And being precise and specific with our words limits the amount of information a person with dementia has to take in and sort out. So use few words and make them count. The way in which we say our words matters too. Maintaining a calm, even, and audible tone contributes to the environmental factors and emotional memory associated with setting up successful mobility. This also applies to how we're speaking to people with dementia. Even though we're adjusting our timing, our rhythm, and the words we use, we're still speaking to adults who have had entire lives up to this point, and our purpose is to provide care that honors their personhood and experiences. There's a difference between modulating speech and infantilizing it that's important to keep in mind when working with people with dementia. Finally, positivity matters. Studies have documented a measurable increase in muscle force production with positive cueing, like "good job, keep up the good work," versus negative cueing, like "try harder," or even just "no." Just replacing the word "no" has been shown to make a significant difference in a person's ability to complete a task. You can try replacing "no" with "okay." For example, if someone starts putting a shirt on backwards, you could say, "Okay, that looks kind of hard. Can we try it this way?" Then help them correct whatever it is that they're doing. Cues should always reflect a partnership. You're doing things with the person, not to them. And we want to be mindful of our language in expressing that. Much of what we've covered today relates to functional activity, but let's not forget the importance of physical activity in the life of a person with dementia. A 2021 study used both objective measures and data from focus groups to identify primary factors for motivating people with dementia to participate in physical activity. At the top of the list was simply going outside. And a close second was playing music that a person with dementia enjoys. Other factors to encourage physical activity are doing cooperative activities like gardening or cooking or constructing. Finding out what activities have been meaningful to the person throughout their life and incorporating that into a daily routine is a good way to engage someone as well. That may require some adaptation and adjustment, so certain activities are still accessible along with changing physical abilities, but any amount of support we can provide people and using their strengths is beneficial on multiple levels. So with that, these are the references used to build today's presentation, and I would love to open up the floor to discussion if anybody has questions or comments.
Well, thank you, Beth. That was a great presentation. Excellent tips, techniques, cues, so many things to consider when taking care of someone with dementia. There are a few questions coming in, and so just a reminder to everyone, you can type them into the Q&A or the chat box, whatever is easiest. So I'll start with this one. So this person has two questions. First, do you get the person to brush their teeth by reasoning the hygienic benefits or by repetition? And then is there a contradiction?
Okay. So that's an interesting question. And as with most things that involve individual behaviors, it depends. So what you're going to think about in deciding what works best for this particular person is where they are in their disease process and what they're responding to. So if this is someone in an earlier stage of disease and their processing time is still mostly intact and you're having full, deep conversations, this is someone who you might reason with. But if it's someone in a later stage and more words, more stimulus becomes confusing to them, maybe they even get agitated if there's too much stimulus around, that's someone where repetition, maybe demonstration, and visual cues will probably be a little bit more successful. And I don't think there's necessarily a contradiction there. Everything that we do, you know, we mentioned briefly, it's all about observing response. So our goal shouldn't necessarily be to do something a certain way. Our goal is to elicit a response. And in this case, the response that we're looking for is someone successfully brushing their teeth. So we can try different strategies and see how it works. And once we find something that fits, sticking with it is the best plan of action. Oh, and then there was a second question. How do you get the patient to stay in bed after being put into bed and not getting up minutes later? This can be challenging. And I would say that to address this, we would want to zoom out from the actual getting them to stay into bed and look at what is happening around bedtime. Are we using good sleep hygiene techniques to help them wind down? Are we, do we have a set routine for right before bed that triggers their response of, okay, we're getting ready for bed. I know this routine, I've done this before. If falling is a concern, if people are getting out of bed and having slips or falls, or people don't know that they're moving, then thinking about some alarming strategies, either video, bed alarm, movement alarms. One thing to consider with those is that they can be kind of distressing for people. It's a loud noise. There are some on the market now that are remote signals, so only the carer is informed if someone's moving. But those are kind of two different considerations in terms of someone getting and staying in bed.
Great, thank you. And I know that Terrence followed up to say his sister suffers from anxiety, and that was the cause of getting her, why she gets out of bed to check the door. So I don't know if there's anything to add with that, or.
So it sounds like sleep hygiene strategies and really developing a solid routine to help her get into the mindset of restfulness would be helpful.
Thank you.
Mm-hmm.
And then Sharon, we have recorded this and we will be sharing it with everyone who registered. So keep a lookout in your email. All right, next question. Is there such a thing as overbrushing teeth, washing hands, showering? My mother successfully completed these ADLs, but brushing 5 to 6 times a day, etc.
That's a good question. And I would respond to it with a question in that, is this activity causing her or anyone around her harm? If not, then I would say no. it's not a problem, and it doesn't seem like something that would necessarily need to be addressed. On the other hand, if the next time you take her to the dentist, he says that she's having problems with her gums because of overbrushing, then you can mitigate that risk by changing the tool, maybe getting her a soft bristle brush so she can still engage in the activity without it causing her harm. There are a lot of behaviors associated with dementia, and repetition is one of them. If it's causing distress, if it's causing harm, then it's very necessary to address it. But in a circumstance like this, where there's not a lot of potential for harm that I'm aware of at face value, then you just want to do a cost-benefit analysis of what it's worth to try and break the habit if it's not harmful when it's occurring.
Thank you. Any more questions? Let's see. I think Terrence was just following up with the.
And I do have my email address up there if anyone thinks of anything or wants to follow up with other questions as well. So Terrence, you're welcome to reach out to me and we can discuss more if you'd like.
And another question came through. What do you do if the patient does not cooperate? Take a break, come back, try to meet the goals you set, or let go?
And again, I would say it depends. It depends on where you are physically, like taking the doctor's office example, for instance. There may be something that you have to get done there. You have to get them to get up and go into the office. In that case, maybe having some redirecting strategies or some actual redirecting tools, something comforting that they can hold on to minimize distress and calm them in the moment. If you're at home and there's an activity that would be nice to do, but it's not necessary, there may be times when letting it go is the right option. But similar to Sharon's question, you're wanting to weigh the cost and the benefit. If something escalates, you have a few different options. Redirecting is a great one, and that can look like therapeutic storytelling. Let's say someone is getting up at 3 o'clock in the morning because they were a postal worker, and they get agitated when people try and get them back to bed. Maybe you use therapeutic storytelling to say, you know what, it's Sunday. You don't have to work today. You can go back to sleep. And that's a redirecting strategy. Again, having accessible tools or even just taking a break, like you mentioned, if things really get escalated. And that's something for the carer to identify in themselves as well. How am I responding to this? Am I starting to am I working myself into a lather? And do I need to take 3 breaths before I continue engaging in a positive, productive way? That's also something to consider in the mix.
And I think just a follow up to the same person, the question you're answering, he gave an example that his mother-in-law keeps waking up at night. How do you help? So how do you help her? Reminding her a few times or letting it go? I think this will be our last question.
And that's a good question. And with that, you're really wanting to get to the reason for her wakings. Is this medication related? Is she, like Terrence mentioned, is she experiencing anxiety when she goes to bed and it's causing an unrestful sleep? Is she waking up in distress, or is she just waking up to get a snack? In which case, maybe you set a routine of, after she goes to sleep, putting something next to her bed so it's there for her. It really depends on the context of the situation and the individual, how you're going to respond to it. But I would say in all of these, being mindful of your tone and being consistent in cues can be really important. So, for instance, instead of saying, "Mom, it's the middle of the night, you have to go to bed," saying something to the effect of, It's 10:45. We like to go to bed at 10. Let's go back to bed now. And being consistent with that every time and getting into a pattern can be helpful.
Well, thank you, Beth. And thank you everyone for joining us today. Hope you found this to be a valuable discussion and are, taking away some tools that will be useful. There is a quick survey for you all to answer. We'd really appreciate if you fill it out. Should take no more than a minute or two. Thank you so much. Bye, everyone.